Take a Satsuma because it has lots of vitamin C. Okay, so our last speaker of the day is Dr. Mark Wilson. He's a clinical assistant professor with the Department of Global Environmental Health Sciences at Tulane University School of Public Health and Tropical Medicine. So today he is going to talk a little bit about some of the risk assessment work that they did with some of the communities in southeast Louisiana that ate a little bit more seafood, I guess had a lot of seafood in their diet. So I'll let him take it away. And so this, if you point, okay, good, okay. We should be good to go.
All right. So thank you for inviting me to come and talk to y'all today. So I'm going to share some of the results from an application of a community-based participatory research project that we were engaged in following the Deepwater Horizon disaster. And we focused on a dietary health risk assessment in a population that was deemed a sensitive subpopulation by virtue of the amount of seafood that they consume and their relatively smaller body weights compared to average Americans. So this study is published in open access in environmental health perspectives. The title of it is a Targeted Health Risk Assessment Following the Deepwater Horizon Oil Spill, Polycyclic Aromatic Hydrocarbon Exposure in Vietnamese American Shrimp Consumers. So this was a CDPR project. We were very heavily dependent on this community to provide us with the parameters that we needed in order to conduct our risk assessment, and that's the primary reason that we focus only on shrimp, is this community was very, very interested in whether shrimp was safe because they eat a lot of it, and also because they are economically dependent on it. Many of our study participants were actually shrimpers. So as we've kind of talked about today in several talks, there has been concern associated with health risks due to contamination of seafood, specifically with oil following the Deepwater Horizon event. So right around the event, there were extensive fisheries closures from May to about 2010 were very large-scale closures. The event received very extensive media coverage, which we're all well aware of. Some of that coverage was a bit of conjecture and a bit of misinformation. And within our community group, we found that they generally had limited trust in information sources, particularly from state and federal regulatory agencies, because they felt that there was limited transparency associated with the types of health assessments and economic assessments that were going on, and that there was poor risk communication actually on the ground and poor local involvement. And some of that was likely due to language barriers within this community because there are a good many of them who are not native English speakers. So we've talked about the reopening procedures, the organoleptic testing and chemical analysis that was used to define whether or not seafood was tainted with oil or not, and we've talked about levels of concern that were derived for PAHs in seafood. So the amount of chemical taint in seafood represents a hazard out in the environment, bad stuff out in the environment. And in order for that hazard to be a risk for us, that we have to be exposed to that hazard. So the organoleptic testing and the chemical analysis allowed us to identify whether or not that hazard is in the environment. And then to derive the limit of concern for those chemicals in the environment, we had to come up with some exposure parameters. And the way that the FDA did this from a federal regulatory point of view was they selected a value that should represent a high level of seafood consumption, in our case shrimp consumption, for an average American. And this was garnered from the NHANES database. So the NHANES is this large database that's maintained by the CDC, and it's the National Health and Nutrition Examination Survey. And it allows you to pull various metrics for nutrition and health for the entire U.S. population. So in up to the top 10% of shrimp consumers in the U.S., can be kind of encapsulated as eating up to 13 grams of shrimp per day. So 13 grams of shrimp per day is not a lot of shrimp, but it includes, in this estimate, people like from Idaho and Iowa and Colorado and all of the landlocked states. So this estimate likely doesn't reflect the actual consumption rate that goes on in coastal communities. The body weight assumption that was used for the derivation of the limit of concern is an 80 kilogram limit, which represents a standard American fairly well, but generally our Southeast Asian Americans tend to be smaller in stature, so that body weight assumption may not be relevant for them as well. So basically, we wanted to get actual information in a community that would represent a worst-case scenario for risk based on high rates of seafood consumption and low body weights, because the way that risk is calculated is on daily dose. And in daily dose, you're looking at milligrams of chemical per kilogram body weight per day. So if you have a smaller denominator, smaller weight, your risk effectively goes up. So first we needed to establish kind of the amount of hazard that our community might be exposed to, and the way that we did this was we contracted with some of the shrimp boats that operate in the fishing grounds in that area, and we wanted to collect from a representative site inland that was never closed due to oil, and also out in the Chandeleur Sound from a site that was closed from the presence of oil. And we tried to do sampling as soon as we could after this fishery opened. So basically this was going to be our unoiled reference site and our oiled collection site for comparison. And these samples were collected within a week of each other in November of 2010. So we collected shrimp on each of those nettings represented on this map. We collected 5 to 10 samples from each netting. The picture on the bottom represents kind of a typical sample. It's just a random grab sample from that netting. And we took greater than 5 gram composite shrimp samples from those nettings and immediately froze them on dry ice and then had them analyzed by GCMS for 81 different individual PAHs. So these included many of the pyrogenic, carcinogenic PAHs that we've been talking about today. And that's the list that we have of the 7 known carcinogenic PAHs. There are many, many other PAHs that we don't really know anything about from a regulatory toxicological point of view. And most of these fall into this petrogenic alkylated PAH category. And we also tested for naphthalines, which are very, very small PAHs, but nonetheless are there. So with our chemical analysis method, we did not detect any of the carcinogenic PAHs above our analytic limit of detection. But in public health practice, we have this thing called the precautionary principle, where you have to kind of assume the worst case scenario when you don't have any information that allows you to exclude it. So since we have a limit of detection of between 0.5 and 1 part per billion, we can't say with any certainty that a chemical is not there below that limit. So we assume that it is there. So there are no zeros in our data set, which is something that causes problems in the way that risk assessment for PAHs is actually conducted. So none of our samples we didn't find detectable levels of carcinogenic PAHs in any of our samples, but we assigned a value of the limit of detection divided by the square root of 2. The reason we chose the square root of 2 is because we were told to by the risk assessment community. So initially, we had decided that we would use the LOD divided by 2, which would effectively cut it in half. The square root of 2 is 1.4, so we're effectively dividing by 1.4, we're dividing by a smaller number, so it's kind of a more conservative estimate in terms of health risk. But effectively, it's just a made-up number that is not a 0, which is an important point. So these are the chemicals that we actually did detect. The gray bars represent our inland reference sample that was not exposed to oil, and the blue bars represent our Chandelure sample that did come from an oiled fishery. So what we detected were naphthalines, small PAHs, substituted naphthalines, 2-methyl-naphthalene, as well as some other PAHs, biphenyl dibenzofuran, phenanthrene, methylphenanthrene, pyrene, and pyrroline. None of these are carcinogenic PAHs, and none of these have a lot of regulatory information associated with them. So two things I want to point out about this graph. We have detectable amounts of PAHs in our inland unoiled samples that are very, very close to our oil samples, and they are very, very low in concentration. So everything pretty much lower than 2 parts per billion, and most things lower than 1 part per billion. Extremely low levels. So there is concern associated with this class of chemicals in these foods based on the presence of them actually being there at these low levels. So this is a graph that shows PAH concentrations that are detected in other types of foods. I'm not going to go into each one of these, but most of these are smoked foods. And if you smoke foods, you're exposing them to smoke, and smoke has a lot of PAHs in it, so that's a good way to instill PAHs into your food. But I do want you to notice the y-axis here goes up to about 35 parts per billion, which is much higher than 2 parts per billion. And the worst food here, and this just breaks my heart, is denoted by this little green square, and it's smoked pork. And no one is really that concerned about food safety issues associated with eating barbecue, even though you can detect levels much, much higher than you can in seafood. So, you know, it's an interesting risk perception issue, but nonetheless, it exists. So in order to address within our community, one, whether or not they were instilling PAHs into their food based on how they cooked it, but also to get very good ideas about their body weights and their shrimp consumption habits, we conducted a survey. So we created a survey both in English and Vietnamese. We put 375 of them out into the community, and we got 114 with complete responses. That gave us about a 38% response rate, which our sociologist collaborators told us was actually pretty good. We had detailed information about body weight as well as shrimp consumption habits, which include the type of shrimp you consumed, the amount of shrimp you consumed, and the frequency of your shrimp consumption. And this allowed us to convert this information using commercial size categories of shrimp into gram quantities of shrimp consumed per day. So our Vietnamese community reported that most often they boiled shrimp. Boiling is not something that's involved with exposure to smoke, so you're not going to instill PAHs into your food using boiling. Usually if you're making gumbos and stews, you're boiling as well, so PAH instillment's not likely there. So the cooking method that is mostly preferred within this community is not something that's going to be associated with increasing the risk. So the only PAH exposure that we were concerned about was coming from oil, and we didn't detect that in our samples. So our body weights, this is a distribution of our body weights, so a range in our body weights. The FDA's LOC determination assumes that everybody weighs 80 kilograms and everybody eats 13 grams of shrimp. So that's not a distribution, that's just a point estimate. This gives you a better idea about variability within a population. Not everybody weighs 80 kilograms. Same with shrimp consumption. Not everybody eats 13 grams of shrimp a day. But this allows you to get a more robust estimate of risk outputs when you actually do risk assessment calculations. So FDA's choice for body weight was 80 kilos. Our average male was about 68 kilos. Our average female was about 59 kilos. So 80 kilos is a pretty large overestimate in terms of this population. Our shrimp consumption rates that were reported within our population were usually around several times per week, and we took that to mean at least 4 times a week. Some people were daily consumers, some were weekly, but mostly it was several times a week to weekly. The size classification that was reported was primarily people ate medium shrimp and large shrimp. And I want to reiterate, these survey respondents are involved in commercial shrimping, so they have a really good idea about what these size classifications mean. So if you ask me if I prefer eating medium, large, or jumbo shrimp, I might not have a real clear idea of what that is, but these folks do. So that gives us a high degree of confidence in this kind of data. So we can use those metrics put together to calculate an average daily intake of shrimp. And if we couple our chemical analysis data with that, that allows us to calculate an average daily intake of chemical. So basically, an average daily intake is calculated by taking a chemical analysis value that tells you your PAH content in your seafood, how much of that seafood do you eat, and how much do you weigh, multiplied by a conversion factor that allows you to convert from grams of shrimp to kilograms of shrimp. But it's basically a pretty simple calculation. And we ran this calculation on our population. So here's our distribution of shrimp consumption garnered from our survey data. So not all of our survey respondents ate 13 grams of shrimp per day. Some ate less. Some ate much, much more. So you might think 322 grams of shrimp per day is a ridiculous amount, but 1 pound of shrimp is 454 grams. So if you think about somebody who eats maybe 2 po' boys in a day, that is not that astronomical of a assessment, but that was also not a very common response. But nonetheless, this information allows us to get a more robust estimate of risk by not assuming that everybody eats the same amount every day. So there are 2 ways that PAH health risks are assessed. One of them is on non-cancer endpoints, and another is on cancer endpoints. So non-cancer endpoints are based on average daily dose comparisons, which are calculated with the equation I just showed, compared to what's called a reference dose. And a reference dose is a dose that's assumed to be a safe level of exposure. So these are listed on EPA's IRIS database, which is the Integrated Risk Information System, and they are available for you if you have the need to know what reference doses are. But they allow you to make very quick determinations of whether or not you would expect an acute health effect associated with a given level of chemical in a foodstuff. The other endpoint is cancer endpoint, and these are calculated as cancer risk based on the average daily dose coupled with the potency of the carcinogenic chemicals in question. So I want to talk about the non-cancer risk assessment findings first, and they are not shocking at all based on the fact that we detected very, very limited things. One of the chemicals that we do have reference doses for that we actually detected was naphthalene. The rest of these we just assumed were there at levels below the limit of detection. And when we couple our chemical analysis data with our average daily intake calculations and compare them to these reference doses, we calculate what are called hazard quotients. So if your average daily dose is about equal to your reference dose, your hazard quotient will be approaching 1. If it's greater than 1, that indicates that there's a probability of health risk. If it's less than 1, there's a low probability of risk. All of these hazard quotient values are 10,000 times, 100,000 times, 1,000,000 times, 100,000 times, and 1,000,000 times lower than 1. So very, very, very low hazard quotients, indicating that there is almost no possibility of seeing acute health effects associated with exposures to these chemicals that were measured in the foods, based on the parameters within a sensitive subpopulation that weighs less than most people and consumes more seafood than most people. But really, what we're worried about in terms of PAH exposure is carcinogenicity. And we've had some good background given by some of the earlier speakers. Basically, PAHs are metabolized to these reactive intermediates that can interact with DNA, form DNA adducts, which sometimes ultimately lead to mutations, and mutations can initiate cancer. So this is the endpoint that we're really concerned about in terms of PAH exposure. The way that risk is calculated for cancer risk is kind of an expanded equation, where we have the concentration of the chemical in the seafood, the intake rate of the chemical, or the intake rate of the seafood and hence the chemical. Here again is a conversion factor. The exposure frequency, how often are you exposed, how many days a week are you exposed, the duration, how long are you exposed, your body weight, and an averaging time, which is assumed to be 78 years, standard lifetime. Multiplied by a slope factor, which is a potency factor for the ability of benzoapyrene, the index chemical of PAH, to cause mutations and cancer, multiplied by a relative potency factor for other chemicals that are not benzoapyrene. So benzoapyrene is our index PAH. We know it's a bad actor, and we tend to compare the activity of other PAHs to it. So benzoapyrene has a relative potency factor of 1. So if you multiply by 1, it doesn't change anything. Benzoanthracene has a relative potency factor of 0.1. Benzo-B-fluoranthene of 0.1, benzo-K-fluoranthene of 0.01, etc. So what this means is that this one is 10 times less potent as a carcinogen as this one. This one is 10 times less potent than benzoapyrene. This one 100 times less potent. This one 1,000 times less potent. So if you had a mixture that contained 1 molecule of benzoapyrene, 10 molecules of benzoanthracene, and 10 molecules of benzo-B-fluoranthene, you could distill that down into 3 benzoapyrene equivalents. And that's how the level of concerns are usually expressed in terms of benzoapyrene equivalency. So what we did is, instead of running a single calculation, choosing a single value for the concentration in seafood, for the intake rate, for the exposure duration, and for the body weight, we supplemented these with distributions from our survey data and then ran these calculations 10,000 times, which allowed us to get an output distribution instead of an output estimate. And it gives you a stronger, more robust way of actually looking at risk because you have more than one data point. So initially we ran our health risk calculations on a cancer endpoint with just the 7 carcinogenic PAHs. And when we do that, our mean cancer risk level comes out at 2 times 10 to the minus 7, which is 2 in 10 million. The acceptable risk range usually used in policy-based risk assessments ranges from 1 in a million to 1 in 10,000. For the level of concern derivation, it was 1 in 100,000, which is 1 in 10 to the minus 5. So that's the metric for comparison here. So we are 10 times lower than the, 100 times lower than the LOC derivated risk of 1 times 10 to the minus 5 at the mean level here. We're still in that range at the 95th percentile, and at the 99th percentile, or the most extreme case, a very small person that eats a whole lot of seafood is at 2 times 10 to the minus 6, so still within the acceptable range. Now I want to point out that these risks are calculated on the assumed values of non-detects being there below the limit of detection. This is in the absence of actually detecting carcinogens. So the policy-based process looks at these 7 carcinogenic PAHs, but we have the analytical capability to look at many, many more. And when we apply the precautionary principle again, so if we're going to apply the precautionary principle and assume that our limit of detection is not the absolute bottom and that things are present below that, then we also need to assume that the chemicals that we don't know anything about from a toxicological point of view are as bad as the worst case scenario. So when we start making those assumptions and lump more analytes in, so if I have my 7 carcinogenic PAHs and then add in all of the other unsubstituted PAHs with the same assumption based on the limit of detection that they're present somewhat below the limit of detection, so again, there are no zeros in the data sets, the risk levels jump up to 1 times 10 to the minus 5, which is the acceptable risk level for the FDA's LOC derivation. 4 times 10 to the minus 5 at the 95th percentile, and 8 times that at the 99th percentile. Again, in the absence of actually detecting carcinogens. When we add all of the 81 into the picture, every single chemical that we could possibly include in our risk assessment, we're above the margin of safety for an acceptable level of risk based on our mean risk calculations. We're 6 times above it at the 95th percentile and at 10 to the minus 4 in the 99th percentile, which is an order of magnitude higher than we want to be. So all of this can be used to indicate that there is a problem with the seafood, but all of this is a mathematical artifact of the way that the risk assessment process is done. But nonetheless, this risk assessment process is the policy-based risk assessment process for the derivation of levels of concern, as well as for deciding whether or not those LOCs can be used to say this fishery should be open or this fishery should be closed. So this process is in the process of being changed, but that is something that is required, that requires change at the federal level, so that process is very slow. So we need, as public health practitioners, to be very careful about how we apply the precautionary principle to additive models like this. So this is what's called a sensitivity analysis that allows us to look at what drives the risk that we see. So we see very low levels of risk. And when we look at cancer risk here on the y-axis compared to the amount of benzoate pyrene equivalents we detect, we don't see a strong relationship at all. When we look at body weight, we see a slight negative relationship, but it's not strong at all. And when we look at intake rate, we see a nice linear relationship. And what this indicates is that what risk is there is driven by high rates of consumption of a single commodity. And that's an important point in and of itself. So in conclusion, the standard exposure assumptions that were used to derive LOCs don't accurately reflect exposure potential for high-end shrimp consumers here in the Gulf South. We cannot say that there is an unacceptable risk that you can infer from our chemically analyzed shrimp samples because most of our samples are non-detects. What risk we can detect is driven solely by high levels of consumption. A fact is that tox literature is really lacking for many of the chemicals which may be detected in seafood samples. We don't know a lot about alkylated PAHs in terms of toxicity. So we need to be very careful with the assumptions that we use making risk calculations based on those chemicals. So risk assessment issues that are associated with the precautionary principle is that risk for PAHs is calculated as an additive model. We turn things into benzoate pyrene equivalents. And if we don't ever have zeros in our data set, as our analyte list grows, our risk level raises every single time. So with that in mind, what do we do with non-detects? We can't call them zero because there's policies against doing that. So we have to be aware that we can declare things unsafe in the absence of actually detecting any dangerous chemicals at all. And this is going to be a problem with increasing numbers of analytes. So as our chemical analysis methods allow us to detect more and more things, we have to be able to incorporate them into our risk assessment models. And the current model is going to have problems doing that. And the current risk assessment model is really based on individual chemical exposures, not on complex mixtures. And realistically, out in the environment, we are exposed to complex mixtures of chemicals. And although we lack regulatory and toxicological information on many individual chemicals, we really lack regulatory and toxicological information on complex mixtures of chemicals. which brings us to the ultimate question for public health practice is, with all of this in mind, how do we communicate our findings in a meaningful way to our stakeholders? And this is something that can be really, really problematic, particularly when a lot of our stakeholders have limited trust in us to begin with. So our chemical analysis was not carried out in our academic laboratories because our community group was not interested in having that done. They wanted it done at a for-profit lab because they didn't believe that we would give them actual results. So, you know, these trust issues are something that we all have to be aware of, and we all need to make sure that we find ways to mitigate them to effectively communicate real problems, or the absence of problems, more importantly. So these are my acknowledgments. This work was supported by an NSF Rapid grant from Dr. Jeffrey Wycliffe at Tulane. We're part of the NIH Gulf Consortium with the U19 funding mechanism. The Baton Rouge Area Foundation and GERHOP also provides funding to investigate these types of things. And none of this would have been possible without our collaboration with the Mary Queen of Vietnam Community Development Corporation, specifically Daniel Nguyen and Tat Bui, who really facilitated interactions with our community group and Tulane Cancer Center. So with that, I'll take any questions. Hope that was fast enough.